talk about in vitro fertilization. And so here I am. I'm coming in. I'm cute, and I want to get pregnant, but I've been trying for a year, and I have not been able to get pregnant. Okay, and so you're going to tell me exactly what's going to happen in the process of in vitro. Now, everybody pay attention and listen, because this is huge. You don't hear this information. You only hear it from Dr. T and Dr. MK. So she's going to give you what exactly happens to get you in vitro.
Well, the first thing is in vitro, or IVF, is one of the more invasive treatments that we do, but we start out with a comprehensive evaluation first to see if you even need to get to IVF. For a lot of patients, we can do less invasive, less expensive treatments that will be effective. And so our evaluation always starts off with a general health screen for the woman, assessment of her ovarian reserve. It's also important to look at the anatomy of the uterus and the fallopian tubes and make sure that those are normal and that the tubes are open. Also, a semen analysis, if there's a male partner involved, is very important in that initial evaluation. For about a third of couples who come into a fertility office, even after we do all of that testing, we won't find a specific cause for their infertility, and they fall into this category of unexplained infertility. If that is the case and we have good ovarian reserve, the tubes are open, the uterus is normal, and sperm is okay, our first treatment is usually to maybe give a medication to stimulate the ovaries to ovulate a couple more eggs during the cycle than the one that we would produce naturally, and combine that with an insemination where instead of the couple having intercourse at home, we can take a concentrated amount of the best sperm and put them higher in the uterus so that there are more of those good sperm that can make it out to the tube to fertilize an egg. That's much less expensive than getting to the IVF treatments. Now, if we get into the evaluation and we find major factors like the fallopian tubes are blocked, the sperm count is very low, or a couple or an individual has tried the less invasive treatments and still not getting pregnant, then that would be a reason to move forward to IVF. Again, IVF stands for in vitro fertilization, which means that we take the eggs out of the body with the sperm and we fertilize them in our lab and then put the embryos back. So we mimic that process that happens naturally in the body, in the lab, and then just transfer embryos back to the uterus. We still start with the complete evaluation of general health, sperm, uterus, and tubal anatomy. And then if we have indications that tell us we need to go to IVF, then we would prepare for that. In doing an IVF cycle, a woman takes high doses of injectable hormones that stimulate many eggs in the ovary to develop.
For how long?
About 10 to 12 days.
So 10 to 12 days.
10 to 12 days, you would take injections
okay,
for
then
twice
next.
a day. And then along with those injections, you come into the office about every 2 or 3 days, and we do an ultrasound to look at the ovaries and see how they're responding, see if the egg sacs are growing.
The follicles.
The follicles.
Okay. Which is where the eggs live.
We look at the follicles and we measure estrogen levels. As each follicle grows, it produces estrogen. So each visit, we do an ultrasound to look at the follicles. We measure estrogen levels to see how the estrogen is rising.
So what is the optimal size that you're looking for, and how high should the estrogen levels be?
Somewhere between about 16 and 20 millimeters, or almost up to 2 centimeters, is the size that each follicle should be when the egg inside is mature and ready to be fertilized.
And how many of these follicles are you, as many as they can grow, or you limit, or you basically...
It varies.
Talk about that.
It varies, again, depending on a woman's ovarian reserve. If the reserve is lower, then we may get fewer eggs from her. If a woman has a lot of follicles or a condition called polycystic ovary syndrome, we may get a high number of follicles. On average, we'll get somewhere between 8 to 15 or 20 follicles. The average estrogen level by the time a woman's ready for retrieval is about 2,500 or so. But again, that's a reflection of how many eggs are present and how many are developing, so it's individual.
Okay, so now where do you go from here? You got your follicles and you're ready to do what?
Yes, so we got the follicles ready, we got the sizes down pat, and so then the woman would take a trigger shot of a high dose of HCG that she would give herself at home, and that triggers the release of the eggs into those follicles and the final maturation of those eggs before we do the fertilization. So you take a trigger shot, and then we schedule the egg retrieval 36 hours after you do that trigger shot.
And that could be at any time. So when it's exactly 36 hours, you have to go retrieve it, right?
Yes. but to make that a little bit easier, we usually do the trigger shots in the evening. Old school used to be that you gave the trigger shot and we were doing retrievals in the middle of the night at 1 or 2 o'clock in the morning.
That's what I remember when I had to do
but
that.
we don't do that anymore. So we
Okay.
do the trigger shots in the evening, which means that the retrieval would be in the morning, 36 hours later. When we're ready for the retrieval, the woman and the partner come in if we have a couple, or sometimes we have donor sperm or different options for the sperm source. But the woman would come in on the morning of retrieval. She's put to sleep in our procedure room in the office, and we do a retrieval or collection of those eggs. This is performed through the vagina, where we have a needle that goes through the back wall of the vagina and into the ovary on each side, and we can aspirate or suck out the fluid in each follicle, and the egg comes with it. That procedure takes about 10 or 15 minutes, and we do that on both sides. If there are 2 ovaries present, we take those eggs out and we give them to our embryologist, who's standing by in the procedure room to collect those eggs.
And this is under ultrasound guidance?
Yes.
Okay, that's
yes.
important.
So we have an ultrasound probe that goes in the vagina, and the needle attaches to the probe. So we're looking directly at the ovary, advancing the needle into each follicle and aspirating, collapsing that follicle, and taking the egg out.
Is there any big risks with this?
It is a procedure, so it has the same risks associated. There's a risk of bleeding, infection, potential for injury to structures that are close to the ovaries on both sides, but we're doing this under direct visualization. We use sterile technique, and we're very careful to make sure that those risks are minimized.
And they're very minimal.
Yes, and they're very
They're
minimal.
very minimal.
So we collect the eggs at that time. Usually during the retrieval, if we're having a fresh semen collection done, the husband is doing a collection at the same time. And we get a fresh sample and the egg that we've collected, and we combine those in our lab, either taking the eggs that we've retrieved and putting sperm in a dish with those eggs and allowing them to fertilize naturally. We can do an injection of 1 normal sperm into each egg that we collect, if there are any concerns with that. So we do the fertilization the same day that we collect the eggs. And the following day, our embryologists look at the eggs that we have combined with sperm to see which ones actually fertilized. Even if we inject sperm into the eggs, that does not guarantee fertilization. There's still physiologic processes that need to happen when the DNA of a sperm and an egg get together in order for fertilization to continue on. So of the eggs that fertilize, we monitor them daily in the lab to see how they're developing through the embryo stages. And either on the 3rd day after collection or the 5th day, we will take those embryos and transfer them back to the woman's uterus. Again, under ultrasound guidance, so we can be sure exactly where we put the embryos in the uterine cavity.
Wow. It's changed from the last time I was in school and we did this.
It's very
We used to get
technical
up at 3 o'clock in the morning,
Yes.
grabbing those follicles.